not, such a simple procedure, but I will definitely take to the medico-legal litigations in hysteroscopy and how to avoid them. As I had said in the beginning itself, the diagnostic hysteroscopy has revolutionized the treatment of benign diseases for gynecologists as far the AUV and infertility is concerned. But I find, beside that it is so very safe and well tolerated, there can be life-threatening complications which have been reported with diagnostic hysteroscopy or when you do a small procedures.
Okay, so this is your number.
Prevention of complication, that is death,
so वो 2 मिनट में
important step to provide maximum care. Maximize patient safety.
म्यूट कर लीजिए.
Careful surgical planning with proper preoperative evaluation is necessary. Now, preoperative evaluation, Dr. Renu had already highlighted, you have to have informed consent in evaluation, a detailed medical history you need to take, and a complete pelvic and general physical examination need to be done to know what is the size and the mobility of the uterus. Now, timing and endometrial preparations it should be rightly done in a follicular phase. It's preferred, but because when you do in a secretory phase, thickened endometrium can mimic endometrial polyps and lead to inaccurate diagnosis. Also, during menstruation, blood may interfere with visualization, so not done. A common cause of litigation in hysteroscopy, which I've seen as a DMC and NMC expert, is that there's an air embolism with inadvertent entry of the air while changing the saline bottles, or a fluid distension media can lead to fatal embolism. Uterine perforation, inadvertent perforation can damage adjacent organs leading to litigation. Bowel and bladder injury, excessive fluid absorption because of the fluid overload syndrome, poor patient selection. Performing in hysteroscopy in high-risk patients, and a lack of informed consent. Improper equipment handling, Dr. Renu has highlighted, inadequate surgeon training, failure to recognize complication, documentation error. Now, who are caught in litigation? Whenever the cases have come in front of the NMC or the National Medical Council, it is always big names. I don't want to highlight it. And I find as a cervical preparation and dilatation is important. Adequate cervical dilatation is important step in hysteroscopy, as nearly half of the hysteroscopic complications are associated with difficult entry of the hysteroscope through the cervical canal. Although the cervical dilatation is not required for most patients, but few patients who definitely benefit from cervical dilatation include those with history of cervical stenosis, previous cervical surgery, nulliparity, and postmenopausal patients at times. Timing and selection of approach. Cervical dilatation can be done mechanically, or it can be done with cervical ripening agent like misoprostol. Preoperative dilatation is generally preferred to intraoperative dilatation because it avoids or reduces the need for mechanical dilatation and the associated risk of pain, uterine perforation, and a false trap. Timing and selection of approaches. In 2015, there was a meta-analysis of 19 trials, and it showed that a preoperative cervical ripening with misoprostol is much better than the cervical dilatation done during the procedure. Misoprostol is to be used in the dose of 200 microgram, taken orally or inserted vaginally 2 to 3 hours prior to hysteroscopy. As for the prevention of infection is concerned, routinely prophylactic antibiotics are really not required because the infection rate is less than 1%. It is good that the people who are beginning to do diagnostic hysteroscopy, anesthesia should be given in 100 cases, so at least you are absolutely well versed as far as this small procedure is concerned. Operative challenges are difficult entry and a poor visualization. Difficult entry in diagnostic hysteroscopy is because of cervical stenosis and preoperative cervical ripening with misoprostol and or small diameter instrument, as Dr. Renu said, that you can use even 2 millimeter in case if you're doing an office hysteroscopy. All things which are done, there are different procedures. People do vaginoscopy and then, there is an entry of hysteroscope through it, but people like us are conventional. We put a sim speculum and hold the anterior lip of the cervix. People like me pass a 12 Nell catheter, and in case if 12 Nell catheter passes easily, there will never be any difficulty in doing diagnostic hysteroscopy. Uterine malposition, whenever you find that the uterine, there is a extreme uterine retroversion or anteversion, definitely it gives problem. But the traction with retinaculum on the posterior anterior lip of the cervix often straightens the uterine axis. Please note that malposition may increase the risk of uterine perforation. Poor visualization can be easily sorted out by histomat because you require for a couple of seconds, especially in a diagnostic hysteroscopy, the distension to be there to have a panoramic view. If this difficulty is encountered, it is likely that there is an obstruction in the uterine cavity, synechia or anything, or a false tract has been formed. Complication as far as hysteroscopy is concerned, a multi-center trial of 92 centers covering 21,000 diagnostic and operative hysteroscopy showed that the complication rate is too low, 0.22%. The most common complication was perforation of the uterus, air embolism, followed by fluid overload and bowel injury. As far as my experience with these, sitting in these bodies, that the Delhi Medical Council and National Medical Council, I can definitely tell you that simple procedure out of all gynecological procedures which come for litigations, more than 50% are simply hysteroscopy, and all these big names. How to reduce the reduction and the patient safety strategies? The comprehensive informed consent has to be there. Clearly explain the risk, alternatives, and potential complications. Proper patient selection, assess the comorbidities and contraindication thoroughly. Use of correct distension media, avoid air, which we do not do it, prefer saline or a glycine with careful monitoring. Continuous fluid monitoring is what we're going to hear from Dr. Milind about. That is very important. Limit procedure duration. Keep short procedures within safe time limits. Routine equipment check. Immediate recognition of complication. Act promptly if complication has arisen. Detailed documentation, that is, record every step, findings, and intraoperative events meticulously. As for the air embolism is concerned, it can occur with any hysteroscope technique and can cause cardiovascular collapse. If air embolism is suspected, the procedure should be terminated immediately. The uterus is deflated and the source of fluid is also removed. The supportive care has to be given, including a mechanical ventilation, and every form of resuscitation is the cornerstone of management. The patient should be shifted to intensive care unit. I find in quite a few cases where air embolism has occurred, the mortality will be inevitable. Electrosurgical injury, thermal effects of radiofrequency or a laser therapy may cause injuries to the uterine cavity as well as bowel. For that, you have to be a skilled person to, to do the procedures. Infection, I have already told you, there's hardly any risk. So, as for concluding slide is concerned, although the diagnostic hysteroscopy is safe, highly effective, minimally invasive procedure, the complication can be a life-threatening, and a preoperative workup is must in elderly patients. Because of most of the patients undergoing hysteroscopy are young, healthy females, and if it becomes even more important to be extra cautious and prevent all possible complications. Proper technique, good training, knowledge of complications and their management can prevent most of the adverse outcomes.
Thank you, ma'am, for discussing the most important part of hysteroscopy. I think we all should be aware of all these facts. So, Dr. Neena Bahl, who does a lot of hysteroscopy, she is there with us. Dr. Neena Bahl, ma'am, your comments about the medico-legal aspects.
Yeah, absolutely.
Let me share it with you. In a city of Delhi, only people who die, 20% litigations are there. In 80%, they get away, they write down, we did everything, post-mortem is advised, but the post-mortem, majority of the relatives refuse. So it becomes their trump point and they do not go for litigations. But something has to be done for diagnostic procedure or small procedures having an air embolism. I don't want to give the names of the people which I've seen in the last 25 years of mine. Is there big names? So please tell us something, because we want everybody to do it, but at the same time, how to get rid of this particular air embolism problem.
So, see, what I would like to add here is with the air embolism thing, one thing very important is all of us should know that the head end should not be low during hysteroscopy. It should be flat, and immediately, if you are suspecting that there is a problem, immediately make the head end up and deflate the uterus, which ma'am said. And also, very important, like what I do with my patients if I am doing myomectomy. So it is very tempting if there is a residual myoma left, if it is taking more than half an hour or there's a little bit of fluid deficit, one tends to keep on doing it another 2 minutes and I'm doing it another 2 minutes. But that temptation should never be, we should never give in to that temptation, number one. And number two, before I do hysteroscopic myomectomies, I tell all my patients that it may require a second sitting. And I document it in the file that second sitting may be required in case there is any kind of fluid overload or the residual is remaining, and the time which taken is, because the more larger time you take to do a procedure, the chances of fluid deficit are going to be there. And it should be written in the file that I've explained it to the patient that this may have to be repeated in second sitting.
Neena, let me repeat again. It is not the big procedures which is killing a patient.
Mm.
It's a small procedure. Yes, please, sir.
Yeah.